This is the Physical Activity Researcher Podcast, a podcast for researchers of sedentary behavior, physical activity, and sports. Join for a relaxed dialogue about research design, practicalities, and, well, anything related to research. Learn from your fellow researchers useful and relevant information that does not fit into formal content and limited space of scientific publications. And here is your host, researcher and entrepreneur, Olli Tikkanen.
Welcome everyone, I'm here at the Norwegian School of Sports Sciences and looking forward to our discussion with the guest of today's episode. He's working as a researcher at the Department of Sport Medicine at NIH and as a researcher in energy balance and breast cancer aspect study at Oslo University Hospital. His research is focused on physical activity, sedentary time and metabolic risk factors. He is currently working in the Generation Sedentary project. Ladies and gentlemen, I'm honored to introduce our guest, Anders Husøy. Welcome.
Thank you. It's pronounced Anders Husøy in Norwegian. I know it's very difficult.
Say it again. I try to go it.
Anders Husøy.
Anders Husøy.
It's even got one of those letters that we only have in the Norwegian or the Scandinavian alphabet.
Yeah. Usually I actually remember to ask that how do I pronounce the name, and then I try, but it still goes wrong. But yeah, that's good.
Not that important.
Yeah. No, it's I think it's our names and and so on. Yeah. So you are working in the project interestingly named Generation Sedentary. Could you tell more about this project?
Yeah, that's a large umbrella project focusing on, I guess what we call the Generation Sedentary, the generation that's growing up now, which is more sedentary than ever before. We see a lot of technological advances, which make them probably more prone to entertain themselves in sedentary type of activities such as smartphones and computers, TV series, which are accessible everywhere at any time. And my particular project is a follow-up study of a group of people that has been measured at our place or at the NIH 2 times before. They were here as 9-year-olds and they were here as 15-year-olds, and now they are on average 23 years of age. So what we'll do now is to invite them in again, and we will measure their physical activity levels, their amount of sedentary time, physical fitness, and also different cardiometabolic risk factors.
All right, so quite a nice longitudinal setting of 20 years almost. No,
yeah, it's
13. Yeah. And what kind of things you have measured from them? What variables you have measured?
We have fasting blood samples, a DEXA scan and the body composition. We have a physical fitness measure, and we have a questionnaire. So we'll do the same again. Now they are grown-ups, obviously, so their parents are not involved. They were involved the first 2 times. But now basically we want to see both how their activity levels have changed with objective measures. And we want to see how their fitness levels have changed, the risk for developing cardiovascular diseases, how they have changed, and whether or not maybe we could find some correlates of physical activity that can act as determinants, so that we might figure out who or why some people remain active and why some become inactive.
Yeah, and you said questionnaires and also objective PA. Have you measured both or?
Yeah, the questionnaires are more about behavior and attitudes towards physical activity and health in general, but also some short questions about diet and general exercise habits that they have now.
Yeah.
So it's not really a physical activity questionnaire. So the physical activity measurements are from the ActGraft, an objective measure.
All right. Yeah. And you measuring it from the waist or?
Yeah, on the hip, same as we've done earlier.
Yeah. So can harmonize the data.
As well as possible. It's difficult with physical activity data. It's such a fluctuating variable in nature.
Yeah. And they are now 23. Have you already done the measurements for this time point or?
No, actually, we're starting inviting next week.
All
hopefully.
right.
So we'll start call, and we'll see. I mean, we have 731 that we can reach out to. We have set a goal of including 400 of them. We know that we won't get everyone, but we have managed to offer them 1,000 kroners. Norwegian kroners, or about 100 euros if they participate, which we hope may be important to those who are in doubt. But of course we don't know, and we hope that they will participate. But it's always, it's a lot of the study will be done in the data collection, and hopefully we'll get everyone. Most certainly we will get quite a few, but I mean, if we get 400, I will be very happy.
Yeah. I was actually about to ask about the dropout. How many you had when they were 9 years old?
1,300 agreed, I think, but I think we have data on about 1,100.
All right.
So it's 731 now, and it's likely to be around 400. So obviously it's a massive dropout. And we know that's one of the problems of doing a longitudinal study. It's kind of unavoidable, but we would like to keep that to as low an extent as possible. Obviously, this is also to do with the mechanisms behind the missing data, so to speak. Why have they dropped out? Because, of course, if they who drops out are completely different to those who still remain in the study, then we have no way of predicting what their measurements would have been.
Yeah. Have you tried to track somehow that why have they dropped out? That what could be the reason? So
I wasn't involved in the first two studies, but I know that the dropout analysis was done after from the first to the second study. So that's a report that I would like to read, and I would also look into this when I get all the data. And I think unfortunately, I think it would be very weird if it's a completely random pattern. I think it's more likely to be because of certain characteristics or things perhaps related to physical activity and fitness in general.
Yeah. And you said that you can give small monetary compensation. Do you usually do that, and does it make a big difference?
We've tried now. We don't usually do that, but we've tried now because the budget allowed it. So hopefully it will make a difference. But I mean, I read also quite a recent review on how to keep as many as possible in your longitudinal study. And I mean, there are varying results, but it seems that the most effective way is probably how you handle the data collection, how you are both flexible and the ease of it. So it's very simple for the participants, for example. So if you manage that, then it's probably the most effective way. But of course, I think that some of the 1,000 kroners would be very interesting.
Yeah, I think it might add a little bit of motivation in there. And so basically you hope to have 400, and you have DEXA, and do you have a direct VO2 max test?
Yeah, it's a direct VO2 max test on a treadmill, and also a static grip strength test. So we'll see. It's I think the first VO2 max test was done on bicycle with an indirect measure. So we'll have to look into that as well, how we can convert that as good as possible to get them comparable.
So I guess you will be quite busy doing 400 direct treadmill tests.
Yeah, also we have 3 wonderful master students who will be participating in the testing, but I guess I will be in charge of much of the logistics, which I guess could be kind of a big job.
Yeah, I think always I've been also there, like the logistics, it's quite a big thing, like arranging timetables with people, and if you have 400, I don't know. Do you have any good tricks for how to do it better? Or?
No, I mean, we've talked about it, and it was kind of like I mentioned, I think we need to realize that we have to be quite flexible and do it on the participants' terms. And do it just as easy for them as possible. Just make them show up, and then we have everything planned out, and we have a testing procedure that works, and it's fluent, no hiccups. I think that's important. Otherwise, we'll see, because some of these are placed all around in Norway. So we want them to get here to do all the testing, but it might also be possible to do the testing somewhere else.
Yeah.
Because we want them to get here for fasting blood samples. So we've also said that we will compensate them for the traveling expense that they have. But I think for most people to get up really early and get here fasting, I think it might be a challenge. But I mean, in the very least, we might ask them to wear the accelerometers and fill out the questionnaires, so that we get some data on them.
And Norway is not the fastest one to go by road. Even the distances are not crazy, but
it's such nothing is flat, so you have to go around every mountains or below a sea or a boat over the sea. It's a lot of
I have noticed that it's not that it might look short on the map, but when you actually start driving
it takes time.
And you have a DEXA here for the measurements.
That's why we wanted to get here, because everything that we want to do is here, so it's quite locally, and it's not much traveling when they are first here, and it's probably maximum 2 hours per participants when they are on the house.
And I think you probably haven't done the first studies with the data, as they are quite old, but do you remember what have been found in this project?
It's no doubt that the physical activity levels decline from 9 to 15, and they most certainly will have declined further to now, to 23 years of age. So it's more about perhaps looking into patterns like different kinds of socio-economic status, looking into what characteristics defining those who end up as active. It's more about how and why, because the what is we're pretty sure that activity levels have declined also from 15 to 23. But I mean, on average, they are quite active in Norway when you compare them to other international studies. But still, it's we see, at least in the adult population, that about 2/3 do not reach the recommended levels of physical activity. So it's I mean, if we knew a little more perhaps on why some people remain active and why some become inactive, then maybe we could design even more effective interventions than those we have now, because it's difficult to intervene. It's usually done in school hours, and we have some good ideas on what might be effective, but no intervention has really been effective as to now. And I think we also the interventions are probably not time consuming enough. It's generally too few hours perhaps to really change behavior.
It's not really an easy task to change behavior, whatever it is, basically.
This podcast is sponsored by Fibion. a research device that has been shown to be valid in tracking sitting, standing, physical activity and energy expenditure. Furthermore, Fibion has been shown to be valid categorizing physical activity into light, moderate, and vigorous intensity. In addition to scientific accuracy, Fibion provides automatically produced and easy-to-understand reports for research participants. Get scientific validation and learn more about Fibion at fibion.com/research.
And then you have been also in studies about breast cancer. Could you tell more about this study?
Yeah, after my master's degree, I worked 4 years on the Oslo University Hospital, where we it's still an ongoing clinical trial where we look into the effect of physical activity among breast cancer patients. So these are breast cancer patients with localized breast cancer, stage 1 and 2. So it's no metastasis, and it's about 600 in total that's been included in the study. So it's an intervention study where half gets an exercise intervention and the rest gets regular care. And the aim of the study is to see whether the exercise the first year after diagnosis can, well, in the long run, make them live longer, but also how it affects their metabolic profile, and if it might be effective for the side effects that we see that many get from treatment, also long-term side effects. And if it helps for that, then it might be also easier for many of them to perhaps do things as get back to work and to function normally, and in general have a higher quality of life. So it's not really any results out there yet because it's still ongoing in the data collection. But I mean, it will be really interesting to see because there are. I mean, it wouldn't be the most expensive way of improving health of the breast cancer patients by doing physical activity. I think the big challenge there would be how do we actually get them to do it. Yeah.
And you started already 5 years ago, and you said no publication yet, so it's quite a long intervention. I mean,
it's a 1-year intervention, but it's been a rolling inclusion. So the inclusion have gone from 2014 until now, last year, and then we're still going through the follow-up data.
Yeah. And what kind of training program they have, or exercise program?
It's mostly a cardiovascular program with interval training on high intensity, and also some basic body exercise, strength exercises, and flexibility exercises. So it's more or less a program that you could do anywhere. You don't really need much of an equipment to do it. So that was always the focus: try to do it outdoors and do it in a group, so that you also do it with other people.
And high intensity to save time, or what was the?
I guess I wasn't involved in the developing of the project, so I'm not really sure what the thoughts behind it were, but I guess it was more perhaps to do with the fitness to do, the cardiovascular fitness, and perhaps the thought that it would be the most effective way of exercise, but I'm not really sure.
Yeah, of course. Yeah, harder you go, more you improve. And then you are looking at the metabolic profile. What kind of variables you are looking in this one?
It's just about everything. I've seen the blood samples list is massive. It's huge. So it's more or less any known, and also perhaps unknown factors relating to cardiovascular risk. So we would assume that, I mean, quite a few breast cancer patients now survive their breast cancer, but instead they die of cardiovascular disease.
All right.
So I think for those elderly and breast cancer with low grade, I think exercise would likely. I think it would be likely if they live longer, because there are known preventive effects of cardiovascular disease from physical activity.
Yeah.
We don't know the specific breast cancer mortality in relation to physical activity after diagnosis, but I think it would be, if nothing else, it would be effective for the so-called comorbidity that many get after breast cancer.
Yeah, and you said that it's probably more difficult to get the people actually to do it.
Yeah.
What have you learned with these patients about getting people to do the exercise program?
My experience has been that I've had a group myself actually up here at Sognsvann, so we've been around in the woods and exercising, and my experience is that it's tough during chemotherapies, especially, but the experience is that it's safe, and it's something that they really appreciate. Both that they have a instructor. I think that's been important, because they show up. They feel that they have to show up because they're part of the study, but they're also part of the groups, of the group mentality and the social aspects of being physical active. I think that's been perhaps the most important part, really, that they're part of something bigger. They could share experiences, and there's something almost magical happening when you're physical active with someone else. It's almost always bringing out a positive attitude. So there was never any complaints, never any negative thoughts really when we were there. So I would say, in my experience, that it's feasible, but I do think it's very, very hard to do it on your own, and especially under treatment. I think that is close to impossible. If you haven't a group, or if you maybe also the instructor, but especially that organization, you know the timing, you know the place, and you know the people. So it's much easier in those cases to show up and actually do it.
Yeah. And you said that it's very tough during the chemotherapy, which is understandable. How would you describe how difficult is it to get to do the training? You said it's safe, but what kind of challenges it poses?
It's very often they get what they call cancer related fatigue, which is an expression of being totally exhausted. And there are also several other commonly reported side effects, such as I'm not really sure how to say it in English, but it's like tingling in your fingers. It's against your neural system. So both in your hands and especially under your feet. So for some people it might be even painful to walk during chemotherapy, some sort of chemotherapy. And also for some, their immune system is reduced. So sometimes you should be careful. But during chemotherapy, when people have been really reduced, what we've told them is that it's better that you show up and do whatever you can. Just keep it, you can stay calm. You don't have to participate as intensive in the intervals. You can just walk if you want to. You can walk your own route, or you can stay with us. And people have generally found that motivating, because when they're done with the exercise, even if they've just been a part of the walking, they have a good feeling afterwards.
And how do you arrange it practically that if some people just walk, that the group still stays the same? Like,
it's the good part is that we've done the intervals in uphills. So we've gone uphills, and that's also because not everyone can run if they are elderly and they have perhaps never done it before. Then uphill is kind of magic exercise tool because you can train on high intensity without going very fast.
Yeah.
So what we've done is that we've done the interval uphills, and we've gathered after the interval in the breaks so that we're together again, and then we go on. So the group was never really separated, not at least to a big extent.
Yeah, and I think you don't have problems finding steep uphills in Sognsvann.
No, I mean, you don't have to walk very far, even though this isn't really the steepest part of the country, but it's quite a lot of uphills in here.
It definitely is. Yeah, and so basically you said that the training is safe. Is there some markers that you need to take seriously, like when is it not safe, or what are the...
In general, if you have an ongoing infection, then obviously you shouldn't exercise. And also if you have a very low immune system, you should be careful. I mean, you can exercise, but probably not as intensive as what we've done.
Yeah.
So, but otherwise, it's really more about listening to your own body, because everyone knows their own body, but for some, especially during treatment, it becomes a different body. So you have to learn to listen to it again and take the signals that you get. And perhaps some days you shouldn't work out really intensive. I think it's always better to do something than to do nothing. But it might not be the time where you go out and you do 4x4 or a really high intensive session when you're on chemotherapy. But otherwise, it's not really any restrictions. Of course, listen to the medical advice of your doctor. But I also think that a lot of people get more warnings than they probably need, because it's a lot of nurses and doctors tell patients on chemotherapy that they shouldn't really move, try to stay as still as possible. And I think that is a kind of knowledge that we're evolving, and it's probably something that's going to change in the future, because this thing about exercising during treatment is quite new. So I think it's a knowledge that's evolving, but I'm quite sure that it's not the advice that we'll give in 10, 20 years time.
So it might be your study, this project, that might affect the guidelines.
A part of it, probably, because it's the biggest one that's out there now, I think.
Yeah. And I think there's trend in almost any condition, whether it's a low back pain or something that earlier they put you in a bed for 2 weeks and then like, all right, now you can start doing something, and now it's like keep moving. And I think with all of the conditions it's almost the same. And you mentioned about the tingling in the feet and so on. Is it just unpleasant, but you can kind of just leave it be and just do, or how do you...
So incredibly different. So what I've learned about breast cancer is that it's such a heterogeneous disease. It's called breast cancer, but it acts differently in very many people. So you can almost have 50 different subtypes of breast cancer, which would affect what kind of treatment you get. And then 2 people can get the exact same treatment and respond totally differently in terms of side effects. So some people do this treatment with few or none side effects. That's quite few, but there are people that report that, and most people get some side effects. But I would say that in my experience, probably the most normal is kind of the tingling sensation, or the numbness that you don't really feel what's going on. It's like you're walking on pillows. But for some people, it's always also kind of like a burning sensation. So that it's kind of painful to walk. And I know that now when you get these kinds of side effects, usually they stop the cure a little earlier if it's get really profound in the side effects.
And you mentioned about the cancer-related fatigue. Have you noticed that if they do the training, how fatigued they are afterwards and how much they need recovery from the training?
It's so difficult because what we do, and when we do a randomized control trial, you try to get comparable groups. So every analysis you do is on group level. So if you wanted to do it on an individual level, ideally every person should be in zone control. Unfortunately, that's not possible both to receive the intervention and do the control. So it's impossible to say, because no doubt a lot of people have also been on the training and then felt like they were completely exhausted even the whole next day. So it's very difficult. I guess a lot of people assumes that it would have been even worse if they hadn't been exercising. But that's a part of what we want to see if there are any systematic differences between the intervention group and the control group and how they report their degree of fatigue during that first year and also later. Yeah.
And you mentioned that the training intensity can vary quite a bit. Are you actually tracking the intensity of every training session, or?
There was it was done on there was several different training sites, and I think 2 of them were using heart rate measure and devices, but we didn't at our place. So we did it in the pilot study, and there were in general a lot of user challenges, which it didn't really work out the way that we thought. So we would have had to control it quite systematically to get the data that we wanted. So what we did was just using a subjective scale, the board scale, where we told them to basically, when you do the intervals, you shouldn't be able to talk in complete sentences. So if you're able to do that, you're doing it to life.
Let's have a short break and hear a few words from our sponsor.
This podcast is sponsored by Fibion, a research device that has been shown to be valid in tracking sitting, standing, physical activity and energy expenditure. Get scientific validation and learn more about Fibion at fibion.com/research.
I see that the name of the project is Energy Balance and Breast Cancer. What is the part of the energy balance?
I mean, this is also a big part of the project that has focused on the diet. But I've not been a part of that. But the extensive measures of the diet, both the questionnaires and diaries, but I'm not really sure about the specifics of these instruments, because there are other people that's been responsible for that part of the study.
And do you have any things that you have learned in this project that you would like to share that are usually not in the scientific publications? That what kind of?
Well, not really, other than that it's even though it feels like you cannot walk or exercise, it's always possible to do something, and I think it's about also focusing on the small things, because I think the whole physical activity recommendations and how walk more, exercise more, I think it gets quite polarized. So I think it's either sedentary or it's either active. And those who think that I cannot do that either way, so I don't do anything. And I think it's important to emphasize that even small amounts and even lower intensities can, if you don't increase your fitness per se, then it can increase your quality of life. And in my experience, the group part of the training was completely invaluable. So I think for people in kind of a vulnerable situation, to be a part of something that makes you focus perhaps on something else and be a part of a group, that was probably what I'm most sure was a positive thing.
Yeah. And how do you see that now the guidelines is that the medical personnel might say that don't move? What do you think it should be the guidelines related to sedentary behavior and all the way to higher intensity activity?
It's difficult. I think they could easily have the same recommendations as anyone else. But I think when you have responsibility of the treatment, you probably you think it's better to be too careful than to ask them to do something that might get them hurt or sick or injured. So I mean, I kind of understand that, and until we have some good data, it's kind of understandable that that's the advice that they get. Because they look weak as well. It's something about when you're on that treatment, you feel weak and you look weak to everyone else. But when you're out exercising, there's no doubt that everyone can do something. You don't have to run. You don't have to. You don't have to even have to walk up hills like we did. You could take a simple walk to the store and back.
Yeah.
And just anything more than laying on the couch all day is probably better. And it's also something about not staying in and think too much. Really do something else. Yeah.
I was just having a recording with David Dunstan, and they have done the study that even 2 minutes affects your insulin and glucose response after the meal. So very small things, even light activity for a few minutes makes a difference. So I think it also, maybe with the patients who would be even more sedentary, maybe even less is effective or has a difference.
Yeah, I mean, there's no doubt that the physical activity levels decline on average after a breast cancer diagnosis, and I think such a message is crucial, that even the smallest amounts will be positive for your health.
Yeah. And is there any other project you are working on, or is it these two that you?
It's these two, and it's now it's basically here on the NIH. I was much more involved on the Oslo University Hospital before. Now that part of it is almost over, for my part at least.
Yeah.
But I mean, that's been my research career really so far. These two kinds of studies, two different kinds of studies, but we'll see now. I'm much more in charge of this one, because it's kind of my PhD project, and it will be very interesting to kind of start a study and complete it, and I mean, you get a different relation to the data when you've done pretty much everything.
Done 400 VO2 max tests. So I can see that. And I want to ask, like, I checked the Shanghai rankings of sports sciences, and I saw that the NIH was ranked number 2 in the world from sports sciences. How is it to work in an institute like this?
It's amazing. I mean, I feel truly privileged to be a part of the research team here. It's an open door policy, which means that you can go to anyone basically at any time and ask for things. And I know in a lot of research societies or milieus, it's kind of hierarchical. So you don't go to the professors if you're a PhD candidate, and I think it's also a really positive side here that we always emphasize that that we're a team, and that if you do a good job, then you should be honored for it. And it's kind of a unique knowledge here as well, because we've done these kinds of longitudinal and cross-sectional studies for a long time involving physical activity. So a lot of experience on measuring physical activity, and a lot of researcher who produces quite a lot of scientific work. So I mean, it's really an honor to be here and to learn from those who has done this for many years.
Yeah.
And also the social, it's also something about the social milieu, which is an environment which is really great, both among the PhD candidates, but also among across different genders and age levels. It's not a difference no matter where you work or what you do.
Yeah. And I think even like location-wise, it's quite an amazing place that you have the almost wilderness starting from here. You're in the capital of the country, and it's just emptiness. Like even the road ends up here. Like it doesn't go anywhere from here.
It's tragic. I mean, I even forget about those things. How privileged we really are that everything is around here. The facilities that we can use, and the marka that we call it, the woods up here. So I mean, it's perfect, and it's I guess that's what's something that makes Oslo special compared to other European large cities, is that it has that kind of closeness to the nature.
Yeah. I think not many listeners probably haven't been in Oslo, but it's quite amazing that you have like the forests are just there and all the big hills, and you can see people coming with the metro here. And just with their hiking bag, and they go to sleep in a tent, and they take the metro back the next day or something like this. It's not many capital cities that you do such a thing.
No, and we have a special relation to the woods. I think it's kind of an adventurous people, I guess. We have our own term that we call friluftsliv, which is just like outside living. Not quite that, but it's kind of an expression that relates to that. And it's a big part for many, going out, just taking a walk, but also bringing a tent, a fishing rod perhaps, doing things like that. It's an important part of life for many.
Yeah. It's an interesting term, the friluftsliv. Like in Finnish language, we don't have that. We have word ulkoilu, which is kind of exercising outside, but we don't have this kind of tent living and exercising. I think your friluftsliv includes quite many things.
At least my understanding of it includes that part as well, but it's basically just anything moving outside. When we move outside, not in the city, but more rural areas, or woods, mountains, lakes. Anything you do basically there would be called friluftsliv.
That's very interesting here. And when do you plan to get your PhD finished?
In May 2022.
All right.
Is the planned date. But I mean, we'll start data collection now. I think that will last for a year, probably. Perhaps even a little longer. We'll see. And then I have about 1.5 years. To write up 3 articles and the dissertation. I think that will. I mean, the big challenge is just to get the results in. I think I will feel much more comfortable with my progress when I have everything that I need, and it's all up to me. Because then I can do it on my terms. I can work as much as I want, and I have everything that I need to produce. It's much more difficult when you don't really have your results at hand.
I can see that. And still a last question: where do you see yourself in 10, 15 years? Where do you want to be career-wise?
Very difficult. I mean, I really enjoy researching, and it was just my last year of masters that I really realized that I like this kind of deep dive into numbers and research in general. So I guess I would prefer to continue with researching. I think also, if it's possible, that me and my cohabitant that will go abroad perhaps after the PhD for perhaps 1 year, see something else, work somewhere else, get some other impulses, broaden your network, stuff like that.
Yeah.
But, I mean, in 10 years, it's difficult.
Yeah, it goes on record, so you can then go back whether you went.
If everything goes in an optimal sense in the way that I feel now, I guess in the long term that a professor that I qualify to be a professor would probably be the optimal right now. But these things change, and suddenly your life takes another direction.
Yeah.
So I wouldn't bank on it, but I think I will continue with research.
Yeah. I will get back to you in 10 years and we will have a new interview. It was a pleasure. Thank you for joining the podcast.
Likewise, thank you for having me.
This podcast is sponsored by Fibion. Get scientific validation and learn more about Fibion at fibion.com/research. The Physical Activity Researcher podcast has created an activity tracker purchase guide for researchers. Get your free copy from the link in the podcast description.
Thank you for listening to the Physical Activity Researcher podcast.